Interlocking open wedge distal tibial tuberosity osteotomy. Stabilizing technique in the retrotubercle without complementary screw fixation. After the osteotomy site is exposed, a first guide wire of 2 mm K-wire is inserted 40 mm below the medial articular surface of the proximal tibia towards the tip of the fibular head. Using calipers, line located 15 mm thickness from the anterior edge of the tibial tuberosity is confirmed as a reference for the descending osteotomy. Second guide wire is inserted at the intersection between the transverse osteotomy and the descending osteotomy, penetrating cortex bone just below Gerdy's tubercle. Along 2 guide wires, the transverse plane is cut up to the hinge area using a bone saw and a thin-bladed chisel. After removing the first guide wire, posterior bone cortex is cut using a thin, single-edged reciprocating saw with posterior soft tissue fully retracted. The blade of the reciprocating saw is then reversed and used to cut anteriorly to reach the second guide wire. A third 2 mm K-wire, parallel to the second wire, is inserted at a distance of 15 mm distally from the second wire. These 2 guide wire serves as a reference plane for the descending osteotomy. Descending osteotomy is initiated from the medial cortex up to the second guide wire, while maintaining 15 mm thickness of the tibial tuberosity using a long micro-bone saw or a thin reciprocating saw. A 1.5 mm K-wire is introduced at the same point of the third guide wire and at a 45-degree angle across the proximal tibial bone axis as a reference for the distal end of descending osteotomy. After removing the second guide wire, with the blade of a reciprocating saw oriented distally, the descending osteotomy is completed to reach the fourth guide wire. Another 1.5 mm K-wire, parallel to the fourth wire, is inserted to be tilted 45 degrees proximally from the descending plane as a reference for an oblique ascending osteotomy. Then, using a long micro-bone saw of 40 mm length, an oblique ascending osteotomy is performed along 2 guide wires. The distal end of the tibial tuberosity bone is cut up in a proximal medial to distal lateral direction. After completing all osteotomies, transverse gap opens to intended corrective angle, while crimping retrotubercle plane with a bone grasper and is filled with beta-TCP blocks. If there is any gap in oblique ascending plane when crimping retrotubercle plane with bone grasper, the wedging technique can be employed using thinly shaped beta-TCP block for additional stabilization. As the result, the distal end of the tibial tuberosity fits snugly behind the tibial diaphysis, creating a stable retrotubercle configuration resembling a mortise antenin joint. At this point, stable retrotubercle in knee flexion and extension can be confirmed even before plate fixation.